So now that we've had an overview of diabetes and the mechanisms behind it and seen the complications that arise because of it, how exactly do we treat it? So in type 1 diabetes, the issue is that the body is unable to produce insulin because the beta cells within our pancreas have been ravaged by our immune system and destroyed. Our only treatment pathway is to replenish or replace what is missing, and that is via exogenous insulin, which has been created by bacteria using recombinant DNA. In terms of the administration and pathways, there are two ways that are most commonly used, which are A, injections, and B, via an insulin pump, where the insulin pump is just a 24-hour machine that sits on a patient who has diabetes that constantly injects insulin into the body at a set rate, which is then tuned to the body depending on how levels of insulin change throughout the day. And there's a lot of tweaking required before a good level is achieved. On the other hand, there is just straight up injections given by the patient, given throughout the day. There are two types, long-acting and short-acting ones, with the long-acting one used to maintain insulin levels throughout the day at a basal level, whilst our short-acting ones used to prevent spikes in our glucose levels that occur during meal times. Adverse effects of these treatment options are obvious, that of being hypoglycemia, as well as local allergic reactions, specifically that of injection sites. In terms of type 2 diabetes, as always, as it's not an autoimmune condition, there are always lifestyle modifications that are the first line treatment or non-pharmacological treatment for the disease, and that are of increasing activities, decreasing intake of high sugar foods, decreasing smoking, decreasing alcohol, and all the other jazz that comes with better lifestyle choices. However, when these fail or its intended effects are not seen, we move on to our pharmacological treatment types, and that is via our oral anti-hyperglycemic drugs. And there's a huge line of them that we'll be going through, but the first line, or the most important to know, is that we use metformin as our first line. So first up on the list is Biguanides, or our metformin. And this is the first line pharmacological treatment for diabetes once lifestyle management is no longer sufficient or blood glucose levels are not actually decreasing. And specifically, the mechanism of action is unknown. However, it has been linked to increased levels of cyclic AMP, and that has a wide range of effects around the body. However, those effects haven't been completely detailed, and therefore we can't have a specific way or a very specific knowledge of how exactly metformin works. However, from our work, what we have to work on is that we know that it reduces gluconeogenesis within the liver, and which is a key component of the body's response to glucagon, and therefore increases the body's sensitivity to insulin, and therefore decreases our blood sugar levels as it increases glucose uptake of our skeletal muscles. In terms of adverse effects, the only adverse effects that we see with metformin are weight loss and slight, but not often GI upsets such as abdo pain, nausea, diarrhea, and bloating. And that is why it is our first line treatment, as all the other drugs following it have a lot higher and more severe adverse effects. Next, we have our sulphonylureas and our meglitinides. And basically, a good way to work out and remember which one our sulphonylureas is by the prefix GLI. Examples are our glycoside, our gliptin, and our glipizide. In terms of the mechanism of action that allows for these to decrease blood glucose levels, it's by blocking our ATP-sensitive potassium channels, which increase the cellular membrane potential via increase in potassium levels, therefore leading to a action potential depolarizing the cell, and thereby opening voltage-gated calcium channels, allowing for an influx of our calcium ions that bind to insulin vesicles found in our beta cells of the pancreas, causing them to exocytose or fuse with the plasma membrane and exocytose insulin into the bloodstream. And as such, with increased insulin, we should hopefully have decreased blood glucose levels. In terms of adverse effects is that of hyperglycemia, as well as weight gain, which is as a result of increased insulin levels, which promotes lipogenesis. Meglitinides have the exact same mechanism of action as sulfonylureas. However, they're just have less affinity to the receptor site compared to sulfonylureas, and that is why it is thought of and used less often compared to sulfonylureas, as it's usually only used when a patient is allergic to sulfonylureas. Examples of this are repliclinide and natalide. Next, we have thiazolidinedione, or an easier way to remember them as TZDs, and they can be easily identified via the suffixation of glitazone. Examples are our pyroglitazone and our rosiglitazone. In terms of the mechanism of action, it increases tissue sensitivity via binding to our peroxisome proliferative activator receptor found in our adipocytes to promote adipogenesis and fatty acid uptake from the bloodstream, as well as increasing our glucose membrane transporter, GLUT4, thereby increasing glucose uptake into the body and therefore hopefully decreasing our blood sugar levels. However, there are many adverse effects associated with these drugs, such as fluid retention, anemia, increased fracture risk, increased cardiac events, as well as increase of bladder cancers. So next we have incretin enhancers, and they can be identified by the suffixation of gliptin to the drug name, examples such as sitagliptin and vildagliptin. And in terms of their mechanism of action, they are competitive dipeptide peptase 4 inhibitors. And this basically prevents the breakdown of incretins, as it prevents or inhibits the enzyme that breaks down our incretins. In terms of what our incretin does, it acts to increase insulin release, decrease glucagon secretion, and delays gastric emptying. In terms of the adverse effects felt by this, some patients note that they can feel hypoglycemic when it's used in combination with sulfonylureas or insulin, headaches, musculoskeletal pains, upper respiratory tract infections, as well as pancreatitis. Next, we have our Incretin Mimetics, and they act directly by increasing the amount of incretin in the body. And this stimulates, as noted before, secretions of insulin from the pancreas, as well as inhibits the glucagon release, thereby decreasing our blood sugar levels. Additionally, it stimulates slowing of gastric emptying, which hopefully results in less high peaks after a meal due to the passage of food reaching and diffusing across the duodenum slower, and therefore hopefully reducing the spike in blood glucose levels. In terms of the adverse effects, it results in slowing of gastric emptying, decreased appetite, abdominal pain, nausea, vomiting, diarrhea, and constipation, muscle weakness, dizziness, headaches, and there's a risk of hypoglycemia with the combination of other drugs. Next, we have our SGLT-2 inhibitors, and they can be identified by the suffixation of gliflozin. Examples include dapagliflozin, empagliflozin, and canagliflozin, and others. In terms of the mechanism of action, it acts via inhibiting sodium glucose cotransfers, SGL2, in the proximal convoluted tubules of the nephron to prevent the reabsorption of glucose that is filtered out of the glomerulus and into the Bowman's capsule. This will lead to glycosuria, which is the excretion or urination of glucose, but reduce blood sugar levels without causing a hypoglycemic event. In terms of the adverse effects of this, as noted by what the mechanism of action, increased urinary glucose. Secondly, it will cause vaginal candidiasis and urinary tract infections, as glucose provides a perfect environment or a nutrient source for bacteria to grow. Additionally, if it's used in conjunction with other diabetic treatments, it may lead to a hypoglycemic event. Additionally, as we're removing more sugar from the body, it may lead to weight loss. Last but not least, we have our a-Glucosidase inhibitors, or Acarbose. And they act in the small intestine by decreasing the gut's ability to absorb sucrose and starch. It does this by inhibiting the actions of our intestinal a-Glucosidase, which is responsible for breaking down our polysaccharides into smaller saccharides that the body is able to absorb and process. By doing so, it prevents postprandial hypoglycemia, as the body is unable to spike in our glucose levels, as it's unable to break down our polysaccharides into glucose to push up our blood glucose levels. However, due to this, there is an introduction of unbroken down compounds enter further down into our GIT tract, which usually doesn't happen. And this upsets environment or our microbiota there, and therefore leads to the adverse effects of flatulence, diarrhea, and abdominal cramping. This is a nice summary slide that showcases the different drug classes, their names or ways to remember them, their location of action, their mode of action, as well as its risk to hypoglycemia, weight gain, and the side effects associated with it.